Good morning. It's good to see everyone. I know some of you had to travel in. I did too. Hopefully you made it in easier than I did yesterday. Just so you know, I left my house at 2 a.m. I got here at 10:30 last night, so uh, running a little slow today. But it's so great to see everyone and welcome. As Arlene mentioned, I'm Paige Ezernak. I'm the Director of the Defense Production Act and Emergency Response Authority's Office in IBMSC at ASPR. So what is the Defense Production Act? And some of you have probably heard me give this talk before. If you have, I'm really sorry about that. If you haven't, hopefully you'll learn something today. So the Defense Production Act was signed originally in 1950, and it was at the height of the Korean War. The Department of Defense was having a difficult time getting the materials and supplies that they needed in order to produce weaponry. So the Congress passed the act, the Defense Production Act, which provided the President authority in a couple of different categories. One of those was to prioritize government orders. The other was so that they could invest in industrial base expansion of capability and capacity. Priority rating of orders means that those orders are prioritized and put to the front of the line. So these are usually federal contracts. They're for national defense needs. These are products that are needed in order to, say, respond to a public health emergency. And in the case of HHS, that's, of course, health resources. Title III allows us to invest in industrial base capacity and capability. It incentivizes private industry to work collaboratively with the federal government in order to make that kind of expansion of, for our case, health resource industry. So EO 13603 was signed by President Obama, and that delegated some of those authorities that the president holds to secretaries of different departments. Now, as you can see, it's pretty self-explanatory. There are certain category areas that are delegated to department secretaries. So for transportation, of course, that's transportation. For health and human resources, it's going to be, of course, health, medical supplies. And then DOE has energy, USDA has agriculture, surprise, surprise. So each department, in order to execute their priority rating authority, has a priority and allocation system. In total, it's the federal priorities and allocation system, but each department has their own. For HHS, it's health resource priority and allocation system. So as you can see, the systems for each of those are listed here, but that system does not set policy on how the department is going to execute those authorities. It is a process system, so it details how you would go about issuing a priority rating, how you would go about issuing an allocation order, which is part of Title I. It does not set policy, though, on how that department intends to use that authority. So prior to COVID, we had very rarely used priority rating authority at HHS. We had used it, in fact, maybe 5 times before COVID. And primarily because we had very little visibility into the supply chain for medical resources. And we know that every rating will have an impact, big or small, on other customers, on that supply chain, on those critical inputs and key consumables. So it was very hesitant to use priority rating authority. At the start of COVID, with executive orders and presidential memorandum, HHS was directed to leverage priority rating for specific items originally. That was PPE, durable medical equipment. You saw it for N95s and ventilators. We were prioritizing those orders the federal government had in place with medical manufacturers so that we could backstock or stockpile the SNS and provide those resources to state and locals who had exhausted their resources they were using to respond to COVID. Over the course of COVID, so 20 to 22, which is the height of sort of the backstocking and the supply of resources, we rated 70 contracts. Now, that wasn't necessarily 70 end products. So if you have a contract to supply a product to the SNS, and you're only having problem with one specific raw material or one specific part that you need in order to manufacture that product, we have the capability of rating just that order, just that subcontractor, just that specific material, so purchase orders. And we do that in order to ensure that we have as very little impact on those other customers, that other customer base as possible. And part of that goes into doing our upfront diligence, upfront research. So when we receive a request for a priority rating, we reach out to that company to figure out what the constraints are. We reach out to those suppliers to figure out who their other customers are. If they receive a rated order, how will that impact their other customers? What are the products that they're manufacturing? So in some cases, the request to priority rate a contract for a specific product may impact products that are much more critical to a response or much more necessary in a hospital setting. So really understanding that and kind of gauging what that impact is going to be is critical before we consider ratings. So there were 70 for various items during COVID response. What we also saw in 2021, 2022 with the Biden administration coming in is a request from private industry, medical manufacturers that weren't necessarily making products that were used for COVID response, but were making critical life-saving products that were being used in emergency rooms or in hospitals or in operating rooms, things that patients had to have in order to continue living. So how do we support those manufacturers as well while we're funneling so many resources over to COVID manufacturing, whether it's vaccines and therapeutics or all of the PPE and the devices that were being manufactured, testing kits in order to support COVID response. So it's a fine balance there of understanding that, yes, we do have a critical need to respond to COVID, but there are also critical needs within just the general health treatment base that has to have those supplies as well. We cannot really invest heavily in one at the expense of the other. And so that's something that we paid very close attention to during COVID. We worked very closely with not only intra-agency HHS partners like FDA and CDC and NIH. We worked, of course, across the interagency with DOD and partners that were also kind of monitoring health systems and health supply chains. And of course, the administration played a very big role there, and they sort of brought us all together to work in this space. So during that time, we triaged hundreds of requests for ratings, We had to issue very few of those. Private industry was very willing to help, very willing to voluntarily prioritize orders in order to support whatever that critical need was. Then in 2022, infant formula. So there was a manufacturer who was unable to manufacture, which held a large market share. Of course, that meant that other manufacturers, and there weren't a lot of those, had to step up and increase production in order to fill that gap. In order to increase production, that meant a high demand on all of their supply chains, their suppliers, especially of raw materials. So working with those companies to determine what their true capacity was, could they increase manufacturing? What kind of supply chain did they have? Was it resilient enough to provide additional products or not? Was that going to be a challenge for them? And how could we work with their suppliers of those critical materials to make sure that they had that in manufacture, had what they needed to bump up production and ensure that babies could have the formula that they need? These are children without any options, right? In most cases, this is their only food source. Similar to what we saw with folks that were on feeding tubes, they had similar constraints in their availability of those food products also. So we worked with those companies and that product base simultaneous with working with infant formula because of the crossover in their supply chains. Post-COVID. So as we came out of COVID response and we began to see the supply chain become resilient and start to increase production in areas that were critical gaps, we began reassessing the contracts that had been rated with program offices to pull those ratings. One, if the rating was no longer needed, their supply line had opened up, they didn't need the rating anymore, and that prioritization of those orders was no longer needed. We pulled those ratings off, and now we're proactively working with program offices to determine what are the contracts that they have for just-in-time supplies? What are the contracts that they have that are kind of pull in the case of an emergency, break glass in the case of emergency? What are those contracts that need to be rated to ensure that, in essence, we can continue to provide the support that we need to provide to state and locals? There's a summary of the types of actions that we did during COVID and after. Lessons learned: when worldwide demand increases for something, we're going to see constraints in the supply chain. We're going to see companies who are unavailable or unable to produce products that are critical need. We saw compounding challenges. At the height of COVID response, we saw an ice storm that decimated the chemical production for Texas and Louisiana because both states were frozen solid for a week. So what happens to medical grade resin that's being manufactured and used in medical products, medical devices, medical device packaging? We saw constraints there that put a tremendous burden on the marketplace to try to figure out how to get those facilities back online and producing as quickly as possible. We saw labor shortages. If you have a COVID outbreak at your plant, that those folks aren't going to come in to work. And so those lines aren't going to run either 24/7 or going to run like they are scheduled to run. We saw demand from other industries. Those products used in these medical devices aren't just used in medical devices. Sometimes they are, but most of the time they're not. So those semiconductor chips that were being used in ventilators were also being used in the Ford vehicle that was rolling off of the shelf. Those same manufacturing facilities manufacture both. So there were cross-cutting demand for some of those critical products. And then importation challenges, right? If it's something that we critically need here in the U.S., chances are if it's a global pandemic, they critically need it in the country that it's being shipped out of. So, the challenge of importing products and importing at the scale and the speed for which we needed them was a huge challenge. So, I mentioned the due diligence and the really looking across the supply line. One size does not fit all. A rating is not always a solution to every problem. If your supplier is outside of the U.S., then that rating isn't going to help you. So how do we work with domestic suppliers? How do we try to identify alternate providers of products so that if there is a critical need, we can do that? And we've seen a lot of the private industry is doing that. They are diversifying their supply lines. They are building in redundancies. They are working to ensure that they don't have sole source suppliers or manufacturers. Part of the DPA program at HHS is also Title III. And Title III is a unique authority given to the president to invest in industrial-based capacity, capability, and expansion of production. And that is for primary areas of Title III. You have Section 301 and 302, that is loans and loan guarantees. The president has the authority to issue loans and loan guarantees to private industry in order to scale up production or onshore production of critical products that are related to national defense. Of course, we're talking about these in the realm of health resources. And then we have Section 303, which provides the president authority to do things like grants, subsidy payments, construction, guaranteed purchases or purchase commitments. And then finally, the Title III also provides for what is known as a DPA fund, and that allows the president to put funding into a specific account that enables that funding to be there. It's available until expended. So there is no color of that money. It's there for the time, because most of these investments in the Title III realm are going to be multi-year investments. These are not going to be one and done or one-year projects. These are usually multi-year projects, and having that money put up front in that account in advance of start of the project makes you a lot less reliant on the annual budget cycle. It makes those investments more likely to occur over time. That is a fund that is managed by the Department of Defense on behalf of the president, but these are presidential authorities. So pre-pandemic, if you've ever heard of Title III or the DPA fund or DPA really at all, it was mostly related to the Department of Defense. Prior to COVID and in the height of COVID, DoD had the only active Title III program in the federal government. Any other federal department that had a program or a project that fit within the Title III scope, and that is that it has to fit with requirements of scaling commercial manufacturing or commercializing R&D or investing in emerging technologies. It has to be related to national defense. It has to be something that you could not expect private industry to do without federal government support, and that support has to be the most expedient available option to building that capability or that capacity domestically. So Title III was all run, owned, operated by DoD. What we've seen in the last couple of years is other departments have recognized the need not just to use DoD's Title III capability, but to establish one internally. Department of Energy is working on that. They have some investment that they're doing in these commercial battery production in order to move over to electric batteries. We've seen that with HHS, we see a need to invest in critical infrastructure capability capacity building here domestically. And that offshoring that Arlene talked about, that Don mentioned, is not going to occur overnight. And how can we entice industry to bring that production back to the U.S.? There are a number of executive orders. I'm sure you've seen those. But I think I want to highlight 13944. That executive order specifically required the FDA, or requested the FDA build a list of critical products, medical countermeasures, and critical inputs. These were essential medicines. You may have heard about it as the essential medicine list. It's over 200 products that we saw that were essential to healthcare, that were critical shortage products at the height of COVID. So at the end of 2023, we started requesting or identifying a need to establish a Title III program here at HHS. And working with the administration and HHS leadership and with our interagency colleagues, we put forth a request to establish a Title III capability at HHS. In November, President Biden issued a press release and talked about 30 or so critical things he was doing to invest in supply chain optimization, capability expansion here in the U.S. And the Title III program at HHS was one of those. In December, he signed our first presidential determination. It is not one and done. These determinations are somewhat limited in scope, and so I anticipate that for specific projects moving forward, we'll need additional determinations. But what they do is they allow us, it provides a category of areas of investment that we can leverage Title III, those unique funding authorities to do that. So ours is specifically tied to 13944, that essential medicine list. And when we're talking about the essential medicine list, we're not talking about investment in those products on the list necessarily. There are a lot of products on the list that are critical health treatment needs, but not necessarily related to national defense or medical countermeasure development. We are talking more about the critical inputs to those products. So trace that supply chain back and identify things like API and key starting materials. Identify things that would feed into a number of those end products that are on the list. So how do we do the most good with the least funding? And that's to invest upstream so that critical input can support the production of a number of different types of end products. Right now we have three closed actions. They were active actions a couple of weeks ago. We issued a request for information, an RFI. We have identified a number of shortfalls in domestic production and supply chain, for health resources here during the height of COVID over the last few years. But what we really wanted to hear from industry are what additional gaps are you seeing? Where do you see the shortfalls in domestic production capability? Where are you most concerned about your supply chains, about, there only being one source, one manufacturer for specific raw material that's critical to a number of products or a number of your products? So that RFI closed not this past Friday, the Friday before. And we are going through those now. That information that we're collecting really informs sort of the next generation of projects. Where do we look at as critical investments in the next generation? We also have two current efforts we're working with, and you're going to hear about the BioMap group, the BioMap Consortium in just a moment. That's a collaboration with BARDA, and that allows us to work collaboratively with them, but with industry, to identify areas that we can work with them to coordinate an increase in investment or an increase in building that capability of that specific product, whether it's the API KSM effort that we're talking about or whether it's an increasing alternative sterilization capacity. Those are the two projects that we're working through right now. These were RPPs that have now closed. We're going through proposals, working with the BioMap Consortium. We're really excited about the interest and about the submissions we've received, and we thank you for being great partners in those areas. So really, I want to leave you with those key takeaways, and I know I'm actually doing pretty good on time, surprisingly. I think as I had a little extra time. I don't know if it's worse to be the presentation right before a break or the presentation right before lunch. I'm pretty happy it's the one right before a break right now because I don't want to get between anyone and their food. So, but key takeaways from our discussion today, we understand really in essence that the DPA, those authorities are extremely powerful authorities, and we use them with the respect required for that. We understand the impacts of any rating. We understand the impacts of any investments through Title III, and we want to make sure we're good stewards of those. So we work very closely with industry. We want to make sure that we're hearing what you're having to tell us, and we're sharing the information that we're getting from you for ground truth in lending. How do we continue to collaborate, though, on future projects and investment areas? And I cannot tell you how appreciative I am of the relationship that I've built with many of you. Our team, our office has built with many of you over the last few years. We've reached out to you. You've always been open and willing to communicate with us when we've had requests or questions or wanting information. And that relationship is critical to sort of the next stage of these partnerships. So thanks for coming today.
The question regarding just the way the DPA offices within agencies are structured and how those appropriations work from Congress. Does that money get appropriated in a DOD bill and then funneled into the agencies that have DPA offices, or is it done somehow under a different way?
And so it's a little different than that. Right now, DOD funding, the DPA, quote-unquote DPA funding that's going into the DPA fund is what DOD has requested, and they are executing that funding. The funding for specific projects are requested individually. So although we have a presidential determination that highlights kind of areas that we want to work to invest in, there is no specific funding associated with that. We identify a project, and the funding is requested that way for each individual effort.
More questions?
It was just that good.
She must have done a great. There's one in the back.
Yes, one more question.
Thank you. Thank you, Paige. I'm Stephanie Olguin at VA. Just curious how other agencies, I know there's a lot of discussion about interagency partnerships, but currently at the VA we're working on something called the digital stockpile effort. I think some of you in the room might be familiar with that. How can we get more involved with these initiatives that ASPR and other agencies are currently executing so we work smarter, not harder, and not duplicate efforts?
Absolutely. Please share your contact information with me after this. I will get it to the right folks to make sure that you have a contact and then they reach out to you. We definitely want to leverage what everyone else is doing rather than reinventing the wheel. For sure. Agree. Thank you.
Hi, thank you. You mentioned a recent RFI process that closed. If you find particular areas that you deem actionable, how will you go about addressing that? Will it be through the biomap process? Will it be through other agencies or processes, or maybe is it not yet determined?
I would say not yet determined. I think it'll depend on the project. I mean, I think that if we identify projects coming out of the RFI, we would go through a BAA. Most likely, the Biomap Consortium is something we have the capability of using, but it doesn't necessarily fit with every type of project that has been proposed.